impact. Thanks everyone for joining. As you heard, my name is Adam Marks. I am a palliative care provider and also one of the clinical ethicists here. And today we'll be talking about palliative sedation, controversies, and consensus. So a couple of different objectives for today's talk. Well, first we'll start by attempting to define palliative sedation. This is a little bit harder than it may seem. There's a lot of different definitions and terms used in the literature, but we'll try and get through that and spend some time discussing the ethical justification of palliative sedation, especially where there is consensus across professional organizations. And we'll use that as a launching point to explore some of the controversies around so-called expanded use of palliative sedation. And then because I'm a palliative care provider and I think very much about the words that we use, especially towards patients and families, we'll spend the last portion of the talk on reviewing some elements of emotion-based communication for discussing palliative sedation with patients and their families. But we'll start with a couple of cases just to illustrate what we're talking about. And this first case was one that I was involved with as a hospice physician over 10 years ago now. And it involves a 25-year-old gentleman with a severe form of inherited myotonic dystrophy that came to me. Now, without going into too many details, you just need to know that this type of dystrophy, this myotonic dystrophy that he has, is progressive, it is untreatable, and is characterized by progressive weakness and both respiratory and cardiac failure. He'd been diagnosed 6 years prior to coming to me, and his response to getting diagnosed was to engage in many-year pattern of polysubstance abuse. He had several run-ins with the law, multiple visits to the emergency department and hospital, both for complications of his disease and his substance use disorder. Now, he came to me, to our hospice agency, after a prolonged hospitalization, where he was again experiencing progressive respiratory failure. And during that admission, he and his family opted to forego mechanical ventilation in order to focus on comfort and allow a natural death to occur. By the time I met him, he had lost the ability to speak. He had a G-tube in place, but had made the decision to forego artificial hydration nutrition. And he had been without any form of enteral or parenteral intake for about 48 hours. Now, his clinical course in the hospital had been characterized by pain related to severe muscle spasms. These were pretty impressive to bear witness to, and kind of unclear triggers, but he'd have these very strong, distressing spasms, sometimes in one area, sometimes more generalized, and in the past had broken bones because of the severity of these spasms. And he had had lots of different people sort of thinking about how can we manage these symptoms? And so PM&R was involved, anesthesia, pain service, neurosurgery, certainly palliative care, and had been on a variety of different medications, opiates, muscle relaxants, had intrathecal medications, pain interventions, none of which were able to perfectly manage these episodes of spasm. Continued to be very, very uncomfortable for him. Even though he was nonverbal when I met him, he was showing nonverbal signs of pain. His tense face would be tearful at times, and certainly his parents, who were both there, identified that he was in immense suffering. And the question to me as a hospice physician are what can we do to ensure that his final hours and days are spent comfortable and not in apparent agony. The second case involved a 54-year-old female with relapsed leukemia who's pancytopenic and is admitted to the hospital with severe rectal pain. Now, she's found to have both anal fissures and this complex enterocutaneous fistula. And unfortunately, with her comorbidities, namely the pancytopenia and thrombocytopenia, was not felt to be a candidate for surgery, which would have been the definitive fix for some of her rectal disease and involvement. And furthermore, she was not a candidate for any disease-specific therapy. So she was not a candidate for any further systemic therapy for her leukemia. Now, rectal pain classically is a very, very difficult pain to get on top of. And it was certainly the case for her that her pain persisted despite multimodal therapy. She was on pretty good doses of a hydromorphone PCA. She'd been tried on methadone. She'd also been tried on buprenorphine. Acute pain service had been involved for a trial of intravenous ketamine, a variety of topical therapies, and none of this really worked. Unfortunately, she was not a candidate for, again, surgery, but also she wasn't a candidate for any localized pain procedures. And her pain was really exacerbated by passing stool, which happened about 2 or 3 times a day. At baseline, she'd have kind of moderate achy pain. But whenever she had to have a bowel movement, this would be red-faced, tears streaming, pounding on the wall, agony that would take her hours to recover from. Very, very severe. Now, on hospital day 14, the palliative care team was called to the bedside because she was asking to be put to sleep. Those are her words. And when we came by to assess, she expressed understandable frustration with her continued suffering. Right? We've been working on this for however many days. I am no better. And one of the lines that was said that stood out to me, you wouldn't allow a dog to suffer like this, right? We treat animals better than I'm being treated right now. Now, she is eating, she is ambulating, she is clinically stable, and as opposed to our first patient, she's not at necessarily the terminal stages of a disease. She has a prognosis of potentially weeks or months, depending on development of complications from her underlying illness. And so the question got raised, what else can we do to alleviate this person's severe, severe suffering? But let's get into the topic, palliative sedation. As I alluded to, there are a lot of different ways that this is described in the literature. According to one review, there may be as many as 50 different terms and definitions used. They can include proportionate palliative sedation, is a term we sometimes see, continuous deep sedation, terminal sedation, end-of-life sedation. It sort of makes an exhaustive literature review a little bit challenging. And with these different terms come some different definitions. I think one of the ones that I like is the intentional administration of sedative drugs in dosages and combinations required to reduce the consciousness of a terminal person as much as necessary to relieve one or more refractory symptoms. The emphasis here is an addition by me. But a couple of things to mention, right? We are intentionally using sedative drugs, right, to reduce the consciousness of a terminally ill patient as much as necessary to relieve refractory symptoms. We're going to hone in on some of these terms a little bit later. But the thing to emphasize is that when we think of palliative sedation, this is really a last resort when other attempts to alleviate suffering have been unsuccessful. So sort of highlighted in both of the cases that I presented to you, right? We've tried a lot of different things, and despite that, significant suffering is persisting. So how often does this occur? With those variation in definitions, it's a little hard to tell. You look at the literature, anywhere from 50 to 50% of end-of-life cases are reported to receive palliative sedation. Again, that wide variation reflects really differences in clinical approach. If I have a person who has terminal restlessness and I'm using, let's say, a PRN Ativan, is that palliative sedation? I would argue not. I'm not using that medication necessarily for sedation purposes. I'm using it as an anxiolytic, perhaps. So again, variations. I will say that now the 12 years that I've been practicing as a palliative care physician, I think I can only think of a handful of cases where I've had to engage in some form of true palliative sedation. I think partly too that reflects just the larger toolbox that we have of advanced therapies now for refractory symptoms. Probably no surprise, the most common symptoms cited for palliative sedation are pain, dyspnea, and restlessness. There are a couple of different ways that palliative sedation is approached. Perhaps the most classic is continuous deep sedation, where I am using an infusion or intermittent dosing of a medication to achieve a minimally conscious state. So this is like using a Versed infusion or intermittent dosing of Ativan or phenobarbital to put someone who is to get someone into a minimally responsive state in order to manage that symptom. There's light sedation, where again, either continuous or intermittent dosing is used to achieve a light sedation, where the person still may be able to answer some questions. They may be able to take some hydration, nutrition. And then there's intermittent sedation, where medications are used to achieve sedation only during a certain time frame, sometimes also called respite sedation. And so the way this is commonly described in the literature is using sedative drugs overnight, so that someone can get some rest. Perhaps they, even though they may be experiencing suffering, they want to have a degree of alertness during the day to interact with family or otherwise attend to their environment. Now, it's worth mentioning that palliative sedation does not refer to the unintended, though potentially foreseen, side effects of a lot of the medicines that we use at the end of life. And so many of the medicines that we use, like opiates or benzodiazepines or antipsychotics, will have sedation as a side effect, but that's not our intention when we're using them. Again, we're using them for breathlessness management, for pain management, anxiety, and the sedation is an unintended effect. If you recall from the earlier definition, I emphasize that word intended. I'm using this as a sedative drug. And so, I want to make clear about that because sometimes I've heard the term palliative sedation used when we're using end-of-life medications in sort of the routine way. Okay, so now that we spent some time defining palliative sedation, let's talk about the consensus. So palliative sedation was first described as an entity over 40 years ago, and while it has not been without controversy, there's broad consensus that exists on the appropriateness of palliative sedation when the following criteria are met. And so this will sound familiar. So first, right, the symptoms ought to be refractory, for which all other reasonable treatments have failed. What do I mean by reasonable? Hang on, I'll get there. The second is that the administration of sedatives should be proportionate to the symptoms. Remember that sedation isn't necessarily our goal, it is symptom management. If I can achieve your comfort with light sedation, then I probably ought to be aiming for that. A term we use in palliative care is the lowest effective dose, right, is what we're looking for. So this should be proportionate to the symptoms involved. The third criteria is that the patient should be imminently dying. What do I mean by imminently? Do I mean hours? Do I mean days? Do I mean some range in there? Great question. Again, we'll get there. But this should be, again, saved for those patients at the end of their life. And then finally, I think this is important. We should be talking to patients and their families about what we're doing. So this should be made in full agreement that this is something that we want to pursue for the good of the patient. And again, I think this is quite important, not the least of which is I think there's a lot of misunderstandings in end-of-life care about why we use some of the medications that we do. And I've certainly had patients, families, or even clinicians wonder, are we using these medications in these doses with the intention of hastening a dying process? And I'm always very careful, and many of my colleagues are too, to emphasize the fact that no, that we are not attempting to hasten the dying process. Our job is to support a natural end of life. And I think palliative sedation, we need to be doubly as cautious and careful about how we communicate why we're doing what we're doing to minimize that risk of misunderstanding. Now, if we think about the ethical justification, a lot of what is written invokes the doctrine of double effect, and we'll walk through that in a moment. Actually, we'll walk through it now. So first, for the doctrine of double effect, again, a principle that is oftentimes invoked in end-of-life care, the action must be good, right? And so in palliative sedation, we are attempting to alleviate suffering. We broadly hold that as a good action. The bad effect, potentially hastening death, must not be intended, right? I am intending to relieve your symptoms through sedation. I am not intending to hasten your death. So the bad effect must not be intended. This is one of my favorites. The bad effect cannot be a means of obtaining the good effect. Gosh, Dr. Schumann looks like he's in pain. I'll kill him, so he's not in pain anymore. Whoops, that's a violation of the doctrine of double effect, right? The bad effect cannot be a means of obtaining the good effect. Also, if there's another way of achieving the good effect without the bad effect, we should be pursuing that, right? So if there is anything else that we could try, we should be doing that first. Getting back to that concept of palliative sedation being a last resort option. The good effect outweighs the bad effect. So the risk of shortening life by hours for an actively dying patient is felt to be outweighed by the good of providing comfort. This is, I think, the question of like who gets to weigh the good effect versus the bad effect is an important one. For me, at least, I think about the importance then of involving the family members, right? Do we all agree that this good effect outweighs the bad effect? So that's an important part of that consent process. And then finally, the risk of harm to the bad effect is minimized. So again, thinking about that proportionate use of sedation in these cases. So as we think about this risk-benefit ratio, right, with the doctrine of double effect, it begs the question, well, what is the risk that palliative sedation will hasten a dying process or will hasten death? So we don't have a lot of data. And so I want to caution you that while we do have some, we cannot speak with a huge amount of certainty. Although we've got several small studies that have failed to show a difference between patients who are receiving palliative sedation at the end of life and those who did not. Now, again, these studies are limited. They're cohort studies, limited information on the depth of sedation used, small sample sizes, but particularly when we are using palliative sedation in the imminently dying or the actively dying patient, we have reason to think that palliative sedation has a relatively minimal impact on survival. Another question that is worth asking, is this euthanasia? Right? Is this sort of a wink, wink, nudge, nudge way of getting to euthanasia? And I want you at the end of this talk, if nothing else, to walk away from this knowing that this is in fact distinct for a couple of different reasons. Number one, what's my intention? Again, my intention is to provide symptom relief. My intention is not to hasten a dying process or to bring about a death. As opposed to euthanasia, this is a proportionate intervention. I'm trying to find that lowest effective dose of medication required to alleviate symptoms. And this perhaps is, I think, the most convincing, that death is not my criteria for success in palliative sedation. Your comfort is, as opposed to euthanasia, where we do talk about success rates of interventions to hasten the dying process. The death of the patient is not the criteria for success. So if a patient, family, or colleague asks you, isn't this euthanasia? I hope you can confidently say, no, it is not, for these different reasons. So I talked about consensus. It is broadly held across a variety of professional organizations that palliative sedation is appropriate in the outline that I provided to you, right? So for refractory symptoms, proportionate in the imminently dying patient with consent of patient and or family members, that this is an appropriate intervention. It's been around for 40 years. My own parent academic organization, the AAHPM, endorses this as ethically appropriate practice. So does the AMA, National Comprehensive Cancer Network, HIPNA, NIPCO, I think that's the European Association for Palliative Care, all agree that this is appropriate. Again, in those select cases. So we have this consensus, but let's talk about some of the controversies that exist around sort of the expanded use of palliative sedation. So for those of you who are paying close attention to the definition as I outlined, you might be paying attention to a couple of different words in there. And so the first is that word of refractory. So the use of palliative sedation for non-refractory symptoms is one of the ideas of expanded palliative sedation. How exhaustive do we have to be? Are we allowed to skip interventions that are unlikely to help? For my patient with rectal cancer, rectal pain in general tends to be a heavily neuropathic pain. I have no reason to think that escalating doses of opiates would be effective. She was on moderate doses through that hydromorphone PCA. I had not yet titrated to sedation or toxicity. Do I need to do that to demonstrate? So we have to recognize that the term refractory is a subjective term and certainly can vary from provider to provider. It's also worth mentioning that what one institution considers refractory, another may not. And we are fortunate enough to practice here at University of Michigan in a large, resource-rich environment where I have a variety of consultants on hand to help me with refractory symptoms of a lot of different things, right? So we've got anesthesia pain service, we have interventional pain, I've got PM&R, I have other people, I have pharmacists, I have lots of folks who can assist. Smaller institutions may not have those resources. And do I need to transfer before I can consider something refractory? What if the patient themselves says, I don't want that thing that you're proposing, please. I'd like to skip that intervention. Am I still allowed to call a symptom refractory? Are they then allowed to ask for palliative sedation? Um, for example, again, that patient with rectal pain. One of the things we hadn't tried was intravenous lidocaine. This is an advanced pain therapy. It comes with a variety of risks, including neurotoxicity, including sudden cardiac death from arrhythmias. And it's not too hard to imagine a patient who says, I maybe don't want that thing. That sounds scary to me. Yes, I'm in terrible pain, but and by the way, the days required to continue to titrate that, maybe I'm not going to consent to that. Maybe all I'm asking for is to sleep through some of the suffering I've experienced. Do we allow patients to do that? Another controversy is the use of palliative sedation for so-called existential symptoms. I get asked a lot about this from patients and families, and I have people tell me, I do not want to be aware that I am dying. The idea of approaching my end of life fills me with such existential dread. I'd like to sleep through that, please. In general, use of palliative sedation for existential symptoms is cautioned by professional guidelines for a couple of different reasons. Number one, it suggests that the person maybe isn't imminently dying. If they have the wherewithal to experience that cognitive awareness and dread of a dying process, then maybe they've got more than just hours to days left of life. Some of the cases reported in the literature did not involve the management of, with co-management with psychiatric services. So again, can we really call this perhaps refractory? If I'm not getting subspecialty involvement, again, I think it raises that issue of access and resource availability. And it's important to recognize that psychological adaptation and coping is the norm. It is amazing what we can get used to and can be an opportunity for some real meaning making. I am reminded of a case I was involved in many years ago as a hospice physician of a young woman who was dying from breast cancer. And for her, it was the idea of dying and leaving her two school-age children that she found absolutely untenable. And when she came to the inpatient hospice unit where I was working, she asked, just like the earlier case I described, she asked to be put to sleep. Now, again, I suspected that she had weeks left of life, but was reporting that profound existential dread of a terminal process. Not only that, of course, the unbearable grief of leaving her children was something that she could not sustain. And in that instance, talking with her, emphasizing non-abandonment, and working with her with our grief supports and our social worker and our chaplain, and engaging her in a variety of legacy activities for her children. And so that as they grow up, they would have things to remember her by, something that she and her family found very, very meaningful. And so again, I think that highlights to me, I think, the opportunity for adaptation and coping, even in the face of a terminal process. One of the last controversies that exists out there is use prior to the active dying phase or imminently dying. It will not shock you that refractory suffering is not limited to those who are approaching their end of life. People can have terrible, terrible suffering independent of their prognosis. This, of course, changes our risk burden, risk benefit ratio. The idea of shortening a life by weeks, months, even years versus alleviation of suffering ought to give pause. Now, for those people who are or who have advocated for the expanded use is this idea of would we use artificial hydration nutrition in palliative sedation in this instance so as to minimize that risk of hastening a dying process. It starts to get a little convoluted. So again, an active area of debate among those who are thinking about end of life. And I'm presenting all this here not because I have answers, but as we often find, once we have consensus on something, right, the envelope tends to get pushed a little bit and pushed a little bit. And so I expect that we'll see more of this in the days to come, excuse me, years to come. But I want to spend a little time talking about how we communicate with patients and families who may be requesting palliative sedation. Some of this will be familiar to you who have done training in communication. Some may be novel, but let's get into it. Of course, I think we ought to identify that requests for palliative sedation can be multifaceted, could come from different parties and involve different sort of subtexts. So almost always there is a degree of current suffering involved, either physical or existential. I am uncomfortable and I would like to stop experiencing this, please. Although occasionally this is concern for future suffering. When I am talking to patients and families about a transition to comfort care or a transition to hospice, oftentimes there will be that anxiety around a dying process. Will I be in pain? Will I be aware up into the moment of my death? How horrifying. Are you going to take care of me? And I broadly have to reassure them, right? Like we have a broad toolkit to maintain comfort through a dying process, and we will do everything in our power to make sure however long you have with us is spent comfortable and with your dignity intact. I've had plenty of people ask me for palliative sedation or some form of that due to past trauma related to an end of life experience. I saw my dad die, and I don't want to go like that. I need you to promise me that I won't be experiencing this kind of suffering. And again, lots of reassurance. Sometimes it doesn't come from the patient it doesn't come from the patient themselves. It comes from that family member. I can't imagine bearing witness to my loved one's suffering. I need your reassurance that this will be managed. So sometimes it's that fear of watching someone die in distress that triggers this request for sedation. Um, the questions are sometimes similar in nature to request for a hastened end of life, which we sometimes run into as well in palliative care. Will you please hasten my dying process? And I just always recommend it recognize it as an expression of suffering, the strong emotional statement, and as such it requires exploration. And I'm not going to ask you to do this today, but when I work with trainees, one of the fun little exercises I like to put them through is simply this: name the emotion. We'll come out of a patient encounter or a family meeting or goals of care conversation, and I'll ask the medical student or house officer, what emotion was in that room? And you can see on this wheel, I've plagiarized this from my social work colleagues. Sort of in the center are some of the surface emotions. And most of the times we're pretty good at identifying these, right? Like they seem mad, like they are sad, like they are happy. And I say, great, wonderful, tell me more, right? Use different words to describe the emotion that you're seeing there. And I sort of liken it to when I was in medical school and I was learning how to describe something, right? The physicians I was working with would always press me to be more descriptive. Don't just say it's on the left. Is it anterior? Is it posterior? Is it caudal? Is it proximal? Is it distal? Same things with emotions. The better words that we can use to describe emotions, the more nuanced we can be in our response to them. And so sometimes one of the exercises I put people through is I'll say, when someone is saying, please put me to sleep, I don't want to suffer like this, I'll say, what emotions are behind that? And I'll spare you the suspense. Lots of different emotions can be behind a request like that. Certainly fear, right? Fear of suffering. There can be this despair, this hopelessness, right? You've tried so many things. I am still in pain. Please, you have to do something else. This idea of abandonment, I think of that in that phrase, you wouldn't treat a dog this way, right? I am being abandoned to my suffering. No one is caring about me. The sense of vulnerability, certainly frustration, I think is there. And certainly when it comes from a family member, love and protection. I see this all the time in my work as a pediatric palliative care provider, where at the end of life, families have told me the one thing I can do now is to protect my child. And I need you to promise me that they won't be suffering. And so I think recognition of those emotions can help ground me a little bit as I respond to sometimes what can be very charged situations. But when we're faced with this request, a couple of things we can do. The first is always do your homework. When I get report that someone is asking for palliative sedation or asking for a hastened end of life, I want to know all the things before I walk in the room, right? I want to know the details of the medical case. I want to know the personalities involved, who is making the request. I want to know their communication strategy. I certainly want to know the therapies that have been tried. What have we done already that haven't worked for this person? If I'm anticipating conflict, I want to identify those people that this patient or family trust. Is it the bedside nurse? Is it a social worker? Is it a primary care provider? If I need to, who can I leverage to communicate more effectively with this family or patient where there may already be some damaged therapeutic relationship? Again, thinking of that patient with rectal cancer, they were mad. And they were mad at us, right? So the healthcare system, I've been here 2 weeks and you haven't been treating my pain. So anticipating that conflict and trying to think what trusting relationships do they have that we can take advantage of. But also know your institutional knowledge. Are there any policies about palliative sedation? Does our institution have any history with this? What supports would there be if this is something that we eventually end up pursuing? Step two is this internal reflective step, where before I sit down with a patient and family, I'm asking myself and my team members, how am I feeling? How do I feel about palliative sedation? And how do I feel about this case? Am I upset? Am I angry myself? Am I feeling put upon? If I've been the palliative care provider working for 2 weeks trying to manage this pain and I've been unsuccessful, I probably have some strong emotions about that. And so I need to ask myself, as I'm approaching any potential conflict, am I able to bring a non-judgmental, empathetic, thoughtful presence to the bedside? Or is there something that's going to keep me from doing that? And if so, what resources do I need to bring with me to communicate as effectively as I can with this family? And so I'm fortunate enough to have social work support, spiritual care support on my team. Every unit, of course, has that. So if you find yourself walking into this encounter, again, who else needs to be with me to make sure that we're bringing the best of ourselves to that bedside? Next is the responding to emotion. As I said before, please recognize that a request for palliative sedation is a less intellectual statement and more an emotional one. And as such, we should be prepared to respond to that strong emotion. Many of you will be familiar with the nurse mnemonic for responding to strong emotion. I will go through that relatively quickly here. Simply naming the emotion, I can only imagine how scary this must be, how difficult this must be. Understand through normalizing statements. Of course, you're scared. Anyone would be in this situation. It is normal, right, that you would feel this way. Respect. I find this so powerful with family members, right? I can tell how much you love this person and how hard you are fighting for them. They are lucky to have you. I often tell my trainees that the opposite, of course, of love isn't hate, it is indifference. So if ever you have a family member who is coming at you with some strong emotion, love is behind it. I desperately love this person, and I am doing what I think is best. Supporting through a collaborative plan, right? I want to talk. I likewise want to help your loved one. I want to help you. Can we talk about what those next steps can be? And this is my favorite, exploring the meaning of that emotion, right? You told me that you were scared. Tell me more about that. What scares you? I think that's a very powerful thing, something we often forget to do. Sometimes we'll name the emotion or recognize the emotion, but we'll stop there and we'll miss this opportunity to explore. And that's where we can uncover a lot of information about what might be going on. After we've taken some time to do that, we understand better the emotional issue and the emotions at play here. We should be able to reframe the issue as a shared goal, right? And we really want to avoid, you want this thing, we want something else, like we are an argument. We ought to be able to reframe this as a shared goal. So maybe it's not, you're asking for palliative sedation. I don't think that's appropriate. We want different things, but hey, you don't want to see your dad suffer. That's a very loving statement. I don't want your dad to suffer either, right? We both want the same thing, to provide comfort to your loved one, and I'd like to help, right? Is it okay if we talk about some things that we can do to achieve this shared goal, providing comfort and dignity to your loved one? A big thing that I emphasize in these instances is non-abandonment. I think a lot of times the way we structure these conversations, especially around end-of-life care, is with a focus on the negative, right? We're not going to do chemotherapy. We're not going to do surgery. We're not going to do monitoring. We're not going to do lab draws. And obviously it sounds like, well, you're just going to put me on a morphine drip in a dark room. And I always emphasize something I've learned from some of my colleagues on my team, that the care for you never stops. The care may look different, but the care will continue. We're going to continue all the care that will help, and we'll let go of those things that aren't going to help. an important thing to emphasize in these instances. Step 5 is develop that plan. And we should be focusing that on that shared goal identified. Now, recognize that palliative sedation can elicit lots of strong emotional responses from the patient and family, and maybe the medical providers as well. And so we can prepare for that by saying, again, I'd like to describe some options that I think could help. I want you to tell me your reactions, both positive and negative. So you're opening the door that this may be a really good idea that I'm coming up with, or it might be a terrible one. And I'm going to need your help in sussing that out. Would that be okay? Are we at an okay place to talk about possible next steps for you or for your loved one? And this is where we talk about, this is the medications that we're thinking about. This is what we're willing to offer. If we're thinking about palliative sedation, the expected results, we're talking about deep sedation, light sedation, intermittent sedation, possible side effects. And emphasizing, right, that this is where we're not going to start this plan and then walk out the door. If anything, you're going to see more of us as we are continually assessing your loved one's comfort, and we will change the plan as necessary. I oftentimes talk in these instances about developing a plan and then holding it lightly, and letting the person's body guide us. So if they appear comfortable, then fantastic, that is success. If for whatever reason they don't, then we will reassess and we will try something else. Because again, your comfort, the comfort of your loved one is my primary goal in these instances. I think it's important to recognize that these can be very difficult conversations. It can be very challenging situations. So not forgetting to ask for help. So asking for help from a neutral third party, certainly leadership, either nursing leadership, unit leadership. The ethics team, I think, is available. I should say, I think, I sure do know, is available to provide support. Other clinicians, of course, palliative care, if we're not already involved, probably ought to be involved in these cases. And I'll just mention, right, document. I've been involved now in the years in a couple of these cases, and at times there has been this the question of like, how do I document this in the chart? And the implication is, because we're not just going to say that we're sedating this person, right? Like that doesn't seem appropriate. And I say, time out. Everything we're doing is above board. We need to be documenting very carefully who we're talking with, what we're talking about, what has been tried. So again, the need for documentation goes up in these instances, not down. And make sure that everybody is clear about that. I don't want anyone to think that we're not doing anything that isn't above board. Along those lines, recognizing that for some of the clinicians involved, the providers, that there can be confusion and a lot of moral distress involved. And so not just patients and families, but also the bedside providers, the clinicians, we need to recognize that the impact that this can have. Because I think this is not something that commonly happens, we ought to create space for those providers who don't feel comfortable with this to excuse themselves. I never want any clinician to practice in a way that they feel violates their personal ethic. And we have policies around that conscientious to be excused from those aspects of care that someone objects to. And we should be thinking about the mustering of supports around providers at and after planned palliative sedation. So not just at the time and during, but after someone has died, that very deliberate and intentional debrief, I think is crucially important to making sure that everyone feels supported in the care that they've provided. Also for patients and families, being very intentional and thoughtful about the grief supports after the death. Again, I mentioned about all that conversation I want to happen ahead of time about why we're doing what we're doing. This is not euthanasia. We are not intentionally hastening a dying process. But I think there can be still lingering distress around that. And so wanted to make sure that whatever grief supports are in place, that they will be activated at that time of death for deliberate support to the family. So getting back to the cases and how did they wrap up? The first case involved that 25-year-old gentleman who had that severe form of myotonic dystrophy. And after much discussion with the parents, we opted for palliative sedation. We said that our options appear either awake and in distress or asleep and comfortable. And given the situation of his case, we are opting for asleep and comfortable, and his parents are in absolute support of that, having borne witness to his suffering for many weeks and months. And so on day 2 of hospice admission, we started a midazolam infusion, which we initiated and then titrated to the nonverbal signs of comfort after 24 hours of this titration. He continued to have symptomatic muscle spasms, and we added phenobarbital. He was minimally responsive after that and died about 72 hours later after initiation of phenobarbital. I mentioned this before, but we were not doing artificial hydration or nutrition support for him, which had been at his request previously in his hospitalization. The second case involving our 55-year-old female with relapsed AML. This was a little bit more challenging and more thoughtful. This is, again, not a person who was terminally ill and whose pain was episodic. One of the things we opted to try was intermittent palliative sedation. And so we used intermittent dosing of Versed around the time of bowel movements, which allowed her to balance comfort with a desire to spend time with family. And eventually we're able to arrange for a home, essentially a Versed PCA, where she had a controlled dose of Versed that she was able to self-administer, or her family was then trained to self-administer around the times of bowel movements, which would minimize that distress that she was having, and would certainly lessen her discomfort, but again, still allowed her to have periods of lucidity with her family. And she died around 4 weeks after that initiation of IV midazolam. And so I'll leave you with one of my favorite quotes as a palliative care provider. Being heard is so close to being loved that for the average person, they are almost indistinguishable. I have certainly found that my work as a palliative care provider and my work as a clinical ethicist has driven home for me this point, that listening to patients, not only the words that they say, but the subtext and emotions that are behind it, can have a powerful therapeutic effect. And can, I'm always amazed at the ways that sitting down and thoughtfully listening to someone and responding to them with empathy and compassion on what that can do to heal a damaged or strained therapeutic relationship. And so I encourage everyone as they go forward and they take care of patients in really challenging situations, be it related to end of life or not, just to kind of recognize that slowing down and taking the time to really listen, utilizing those interprofessional supports can make all the difference for caring for the patients that we're involved with on a daily basis. I went through a little fast. I know that we've got some time for questions, and I'm happy to share these slides with anyone who would be interested. Well, thank you very much for taking the time to listen.
Adam, that was a master class in how to approach difficult conversations and communicate effectively. And the best news I can share with the group is that this will be recorded and posted so that you can share it with all of your colleagues and trainees, because honestly, I can't think of better bang for the buck in terms of getting this critical information across. We do have some questions in the Q&A, so I'll read a few of them. So the first one was posted honestly before you addressed it. So I think you covered this to a large extent, but distinguishing physical versus psychological or existential suffering. And it also brings up the question of voluntary refusal of food and liquid in the context of palliative sedation. No need to repeat everything that you said, but I'll open the floor for you to comment accordingly.
Yes, thank you. I think the aspect of psychological, emotional, or existential suffering, that I glossed over, that could be a whole presentation in and of itself. And, while I feel like I spent a couple of slides on it, I want to emphasize that I think that suffering can be the most refractory of all, and the most challenging. And so I certainly don't mean to downplay it. I would share the concern for using palliative sedation for that sort of psychological suffering at the end of life, because my vast experience has been that as difficult as it is, it can be an opportunity for immense meaning making. I am aware that in the heterogeneity of human experience at the end of life, there will be those people, of course, who are unable to achieve any kind of meaning, and it is only distressing for them. And that's where we have to be as thoughtful as possible. The question of voluntary stopping eating and drinking is always an interesting one. I believe, I think it was maybe myself and Dr. Jane Shargat gave a grand rounds ethics on that topic a while ago. That is a means by which a competent person can voluntarily stop eating and drinking. So as to hasten the dying process, bigger topic, I'm kind of happy to talk about that offline. Whoever posted that question, please feel free to reach out to me.
Perfect. Thank you. Next question is distinguishing how double effect intersects with palliative sedation and the inherent subjectivity of determining whether the intervention itself is bad or good versus valuable and meaningful, and who gets to make that decision.
Absolutely, a great question. And I think that does kind of underlie a lot of the challenges of these conversations, as you say, incredibly complex. I think as we talk about sort of developing policies around palliative sedation, the very complexity of these situations makes me a little bit nervous about developing a policy that sort of then lends itself to not thinking too hard when we ought to be thinking as hard as possible about these cases. I think the idea of good and bad outcomes, I agree, is challenging. I've certainly had people say, "Boy, the bad outcome of hastening a dying process doesn't seem so bad for someone with unremittent suffering. That actually seems pretty good." Sure, it may. By and large, we don't hold that as the case in medical ethics. We think that prolonging life is a by and large good thing. I think in order to get around or to minimize that, it is involving all the different players here, right? So wanting to talk to patients and families, do we agree? Are we thinking about this correctly? Getting ethics involved. And so not just one person sitting in judgment and saying, I deem this good and I deem this bad, but trying to achieve a certain amount of consensus and institutional support, frankly, when we're engaging in these practices. So it's a good and difficult question.
Perfect. Yeah, the problem with these questions is they're all hour-long lectures in terms of response. So thank you for doing your best in 90 seconds each, give or take.
Yes.
The next one relates to guilt and regret of family members for those who elect to pursue palliative sedation and how to approach that. I'll flip that as well. Have you encountered situations where families have guilt or regret about not pursuing this, and what your insights might be into either or both scenarios?
I will say that guilt and regret in end of life care, especially for surrogate decision making, is honestly the norm rather than the exception. So for those people who opt to switch to comfort care, there is guilt and regret. For those families who opt trials of aggressive interventions, there's guilt and regret. For those people who say, full court press, I want all the things, there's guilt and regret. And so I think that is, of course, we think of that as a very natural grief response. And so I see it throughout. I can remember talking to, we had a 90-some-year-old gentleman who suffered large intracranial bleed following a fall. We met with his wife afterwards, and she's like, I just feel so bad that I made him a do not resuscitate. Like I felt like I gave up on him. And it was like that, I wouldn't have thought that would be the thing. That seems like such a loving decision, right, to forego that. And I can't claim the invention of these words, but certainly my social work colleagues have taught me that, right? The decisions that you're making for your loved one are loving ones, whatever they may be. There is no right or wrong decision. I'll often say this to families. If there was a right or wrong decision, I'd be telling you what that is, right? This is the decision that you need to make. But it also, for me, highlights one of my many soapboxes, which is this concept of decisional burden, and that we oftentimes place on patients and families, especially for decisions that don't make a lot of sense. And so if we have someone who is obviously dying from multi-organ dysfunction in the setting of an irreversible process, am I going to ask them if they want dialysis or not? Like, how's that going to change what's going to happen? Like, I probably shouldn't. And I do caution my teams that I'm involved with to be thoughtful about what we're offering. We should only be offering those things that we think will have a reasonable chance of help. Because families will feel this burden of I gave up on this person. And so we do a lot of reassurance around that, trying to reframe these decisions. And we have studies that show that if you can get a family to positively reframe an end-of-life process, what a powerful impact that has on grief. And that effect can be felt for years and years. So I'm doing that thing where I talk so much I forget what the question was.
You answered it.
Okay, I'm so glad to hear that. Fantastic.
Perfect.
Great.
Great. We do have a couple more, which just shows the engagement of the audience. And we do have a few more minutes, so we'll go through them. The next one that I'll ask relates to, are there situations, and how would you counsel patients and families when you think that palliative sedation is an appropriate intervention, but it hasn't necessarily been brought up by the patient or family. So is this ever something that you more proactively introduce or recommend rather than something that a patient or family is asking for?
Honestly, no. I'm sure that those cases have arisen. I haven't been a part of that. And I think that reflects the fact that I'm not the one who's suffering. And so a lot of the advanced pain therapies that we talk about, buprenorphine, methadone, ketamine, lidocaine, like these do take days of titration to evaluate their effectiveness, many of them. It's not like I'm doing them all at once, right? I'm starting with buprenorphine. After a few days, no response. So then methadone, no response. So then ketamine, and let's think about lidocaine. And to be honest, there comes a point where when someone's in that kind of pain where they say, stop, like, I need something else. And so I can't think of a time where I've had to say that. Now, I have, now let me be clear. I'm the attending physician, right? I am not bearing witness to suffering the same way that other bedside providers are. I'm thinking particularly of our house officers, and I'm thinking of our nursing staff. Because I do have some of those bedside providers who are bearing witness to that suffering who are coming to us and saying, y'all need to do something. You need to do something more. And so I don't know that it's happened to me, but certainly I've had clinicians approach me before families do and say, this is awful to bear witness to. We need to do something. And that is a very real form of suffering as well, right? The suffering that we feel bearing witness to that distress. And so sometimes this is support, like this is why we're doing what we're doing in education, but sometimes it's also that wake up call of, oh, maybe we need to do something different. So that's, I think, what I can speak to that. I haven't been in a situation where I have proposed palliative sedation and a family or patient said, absolutely not, never will we ever. It is almost always them leading that conversation.
Thank you. Next question relates to the intersection between palliative sedation and hospice services. Is one a prerequisite for the other? Are there times where palliative sedation is better implemented in a acute care inpatient setting? How do you navigate that? And are there barriers or issues that play a role here, either related to logistics or insurance coverage or legal considerations or anything else?
So hospice, definitely not. And I say that because, hospice refers to a very specific form of insurance uh, that has certain restrictions applied to it. And so, for example, when someone is transitioned to comfort care in the hospital, in our hospital in particular, they're not on hospice. So our goals are comfort. We are oftentimes adopting a hospice-like plan of care, but they are not enrolled in a formal hospice program. And so to that specific question, I would say that palliative sedation, the prerequisite is comfort-focused care. It is done with the understanding that, right, you are approaching your end of life and that life prolongation is not our primary goal. Comfort is our primary goal. And we are accepting even the risk of hastened end of life in the pursuit of that comfort. So that I would say is a prerequisite. As to sort of the care location, this is almost always requires some level of higher support that can be done then, say, in a home environment. And so I'm not going to say never would I ever do this in a home environment, but it's hard for me to imagine a situation where I would feel comfortable enough. I'm sure that would exist and that would vary likely from clinician to clinician, but certainly for me to feel comfortable and to make sure that I am minimizing that risk and I am doing proportionate sedation, it would at least need to start in an inpatient monitored environment. So either a hospital or a hospice facility where I practiced for a number of years. Some hospices do have the ability of 24-hour care for short periods of time. And so I could envision sort of as an initiation of palliative sedation in a home environment with that 24-hour support, but that would be a big challenge.
Perfect. One last question, and it relates to the informed consent process for palliative sedation. Is this a situation in which a written informed consent is necessary? How does that intersect with advance directives more broadly? How can you appropriately document this in a way that both makes clear what is being done and what is not being done, as well as to mitigate any potential medical legal implications thereof?
So, the good news is that, from a medical legal standpoint, again, I always tell folks that I don't want to do anything that I don't feel fully supported in doing. And as I outlined, like this is a broadly supported practice, across, professional organizations at the national, international level. And so I feel pretty protected from a legal standpoint. The issue of having kind of a written informed consent, I haven't done that. And I know some policies will have sort of, I need you to sign on this line. I obviously don't do that in other instances of end of life care that potentially has a similar risk. Like if I'm rapidly titrating narcotics for refractory pain or dyspnea at the end of life, we think that there is still a risk of a hastened end of life, but I don't have people sign that thing. The palliative sedation is this sort of discrete construct. I would say if you as a provider feel more comfortable, I think that's reasonable. But certainly having a witness conversation, documenting it in the chart, so it's not just you one-on-one having a conversation potentially with the family, but having other members of your team there documenting it clearly, I think is important and I would argue sufficient. Again, that may vary from institution to institution, what they feel confident in from a medical legal standpoint. But but I could see that being more comforting to all of the care providers. You know, it is one thing for me as an attending physician to sit in the comfort of my office typing in orders. It is another thing for that clinician at the bedside. And certainly they may feel more protected. Now, again, I'm thinking about our bedside nursing. They may feel more protected having that documented in such an official way.
Fantastic. Thank you for such a thoughtful presentation. We will have the recording available for those interested. Please join us for next month's Bioethics Grand Rounds, and please join me, at least virtually, in thanking Dr. Marks for his sage advice and wisdom. Have a wonderful afternoon.
Thank you, everyone.